Can we have Dr. SHREYAS please with his talk on Aphakia management after complicated cataract surgery?
In the previous talk, Dr. Manpreet told about optimizing the visual outcomes after cataract surgery. Basically, I am a VR surgeon, so I have a rehabilitative role. So I will be discussing on rehabilitation in patients who have undergone a complicated cataract surgery. So basically, my talk is Aphakia management after complicated cataract surgery, choosing the right plan. So the incidence of surgical aphakia is less than 1% in modern cataract surgery. Most of the intraoperative aphakia is avoidable if the surgeon is well prepared for such a situation. So coming on to the evaluation part, history is very important. Duration since cataract surgery has to be noted. Associated systemic comorbidities should be noted, just like obesity, claustrophobia, or anxiety, because these might have contributed to intraoperative complications. So in the evaluation, we have to note the best corrected visual acuity. Intraocular pressure should be documented. Coming on to the anterior segment evaluation, we should know the wound integrity. This can be performed through a simple Seidel test. In the cornea, we have to check for the clarity. If any associated DM detachment is there, this can be confirmed on ASOCT. Specular count should be done to note the endothelial status. In the anterior chamber, reaction should be noted. Any residual lens matter in the anterior chamber should be noted. Any vitreous strands should be documented. We also should document horizontal white to white. This is important if you are planning for an SFIL. Coming on to further evaluation, in iris you have to look for areas of damage or chafing. If there is any associated iridodialysis, pupil, it's very important to examine the pupil in undilated state and its ability to dilate and constrict. Also we should assess for capsular support, and simultaneously we have to perform biometry if it is not already available. So posterior segment evaluation is also very important. In the vitreous we have to look for any hemorrhage, retained lens matter, or dropped IOL. Retinal periphery examination is very, very important to look for any associated peripheral tears. So what are the factors which decide what type of IOL should be placed? It's again the surgeon's preference, availability of a suitable IOL, adequacy of capsular support, the white to white diameter, coexistent lens matter or IOL drop, and the timing of surgery, whether it is primary or secondary. So the IOLs currently available for aphakia management include AC IOL, retrofixated iris claw IOL, sulcus IOL. We have either 3-piece or a rigid IOL, and SFL it can be of various techniques, that sutured IOL, haptic fixated IOL, the flanked IOLs, or the newer one, the CMT flex IOL. So we'll see how to deal with this surgical aphakia. We'll go stepwise. The most important part, the initial part, is stabilizing the wound. This is especially important when you are dealing with the posterior segment complication. This avoids inadvertent vitreous prolapse, and also because of vitreous prolapse there might sometimes happen retinal tears or suprachoroidal hemorrhage. So stabilizing the wound is first most important part of managing it. So again now we'll move on to dealing complications of anterior chamber. So we have to do a thorough anterior vitrectomy if vitreous is there. If any residual cortical matter is there, that has to be removed. So when we have defects of iris, or when we have a pupil which is not constructing, sometimes we might need to consider doing pupilloplasty or a iridodialysis repair. So when descent membrane detachment is there, this has to be dealt before planning any other secondary procedures. If the patient has landed up with a choroidal detachment or a suprachoroidal hemorrhage, a simultaneous CD drainage procedure can be planned. So simultaneously, if we have some posterior segment problem like nucleus drop or IOL drop, this has to be dealt before planning a secondary IOL. So coming on to choosing the right IOL, so the most important things which matter are the presence of adequate sulcus support, the white to white of the patient, then whether the pupil is able to constrict, and if there are any associated iris defects. So if there is a dropped IOL already we are having, if we have a 3-piece IOL or a rigid IOL, if the sulcus is adequate, we can go for sulcus fixation. If we don't have adequate sulcus, based on the white to white, if the white to white is of normal diameter, then we can either go for an SFL or an AC IOL. If the white to white is very large or if it is small, we can go for iris claw IOL. If we have a foldable IOL drop, we can explant it, and then either based on the sulcus support we can go for sulcus fixation or an SFL or iris claw IOL. Some surgeons have also designed SFL techniques for foldable IOL where they fix it using sutures. when we don't have an IOL and it's just a case of aphakia and we have adequate sulcus, either we can go for sulcus fixation of the 3-piece IOL or rigid single-piece IOL. When there is no sulcus, again we have to assess the pupillary constriction. If it is constricting, you can go for any of the IOLs, that is iris claw, SFL or ACIOL. If the pupil is not constricting, you can consider for pupilloplasty, and after that again go back to either iris claw, SFL or ACIOL. If there are gross iris defects, then you have to go for an SFL with cosmetic contact lens or for an aniridia IOL. So we will see how a sulcus fixation is done. So most important thing when you are placing a sulcus IOL is that you should have a good sulcus support. At least 2/3 of the good sulcus support should be there, and inferior sulcus support is the most important. So we should always see that we should maintain the reverse S insertion to avoid pupillary block, because we have that anterior 10-degree angulation between the haptic and the optic. So this technique of loading and injecting the foldable 3-piece IOL is very important. First you have to rotate it completely clockwise 180 degree and then again come back anti-clockwise. So these are few techniques of SFL. There are various techniques. This is a video showing Exnic technique of SFL placement. This is another video which is showing a rigid IOL which is placed using an Exnic technique. So there are various other methods like Prolene suture fixation, and this is a flange technique of SFL fixation. So then we have already seen the technique of iris claw IOL. There are two designs. We have a biconvex design and a convex concave design. Convex concave design with the concave surface placed upwards is better. It avoids pupillary block. If you are using a biconvex design or you are placing the convex surface upwards, it is important to plan a surgical PI. So last but not the least, the ACIOL. When you are placing an ACIOL, it is very important to measure the horizontal wide to wide diameter. So your IOL selection will be like approximately 1 millimeter over the horizontal wide to wide diameter. Commonly we have this 12.5 mm IOLs in our Indian market. If it is beyond this, we have to either go for an iris claw IOL or an SFIL. Thank you.